My topic is on the retinotomy and retinectomy. As we go across with the simple retinal detachments to these complicated retinal detachments, or those detachments which have failed, you tend to do a lot more aggressive surgery in these patients. Imagine a situation when the retina flattens under the fluorocarbon liquid, or under the air, and suddenly you see that the air or PFCL is going under the retina, and you suddenly see this retina lifting up. Very often we would have experienced it. This is because of those edges of the retina that is under traction, which we probably have failed to see, and so we need to go back and remove all the air or the perfluorocarbon liquid and ensure that this part of the traction is removed, or by either removing the membranes or shortening the retina with retinotomy or retinectomy. To define a retinotomy, it is cutting the retina, a small hole to 360-degree cuts is called retinotomy, and retinectomy is when you excise the retina, part of the retina. Now, what are the common indications for doing retinotomies? Either it's a relaxing retinotomy or retinectomy, where you do in cases of anterior PVR with severe intraretinal fibrosis to stabilize a retinal break with edges being under traction, or a retinal incarceration into a sclerotomy or a scleral wound. In these situations, you would have to do what we call as the relaxing retinotomies, and the next indication is the axis retinectomies or retinotomies you would do to go under the subretinal space for removing fluids or tissues. As I said, it's done in a pathological site of the retina. There are few rules of the thumb for performing a relaxing retinotomy. As was shown earlier, you definitely need to have a good visualization of the retina, the entire retina. Do a good diathermy when you're going to do a retinotomy or retinectomy to the entire area to be cut or excised. At least some people suggest 2 rows of diathermy to prevent bleeding from occurring in these edges, but again, diathermy could be counterproductive in some situations, folding the edge of the retina. So you do what is adequately required for that situation, and the advantages, it prevents bleeding, and of course in some cases when you're doing a fluid air exchange, you will be able to identify the edge of that retinotomy or retinectomy. When the retinotomy is circumferential, you have to remember that the edges must reach the ora in an acute angle, as you see here, and not like this, because then the chances of lifting is much higher, so you have to have an acute angle with the ora in these cases. Always extend the retinotomy into the healthy retina, not just stop short in the pathological area, to make sure that there is no traction in the edge of the retina. So especially during circumferential retinectomy, at least 1 clock hour you should move into it. And when you do an extensive retinotomy or retinectomy, it is preferable to excise the flap of the retina anterior to the retinectomy, because this can be the site of reproliferation in these situations. Again, the circumferential contraction type of anterior PVR, you could release it by making sure that you make a good vitreous-based dissection, along with the placement of some radial cuts on the vitreous base. While in those cases, in certain cases like circumferential retinotomies are always very stable than the radial retinotomies, and in antero-posterior traction, you can't do away with this radial retinotomies. You would have to do a circumferential retinotomy or retinectomy to have a better apposition of this retina on the back of the eye. In anterior PVR, if you have is usually done after, when you have an anterior PVR, you should make sure that you removed all the posterior membranes before you take care of the anterior membranes, because you flatten the retina, and then you would take care of the anterior PVR. But in certain cases where there is a central displacement of the anterior PVR, you need to relieve, as was shown in this animation, you need to relieve the traction first to have access to the posterior part of the retina. Also, you have to defer doing this retinotomy until you have definitely tried your extensive dissection of the vitreous base. Unless you have done that, do not jump into doing a retinotomy. Make sure that you have relieved all the traction as much as possible. Only in those situations where it is not possible, then you could consider doing a retinotomy or retinectomy. If the retina does not relax, as shown in this case with the perfluorocarbon liquid, then you would consider doing a vitrectomy so that the retina can fall back in its position, as you can see here in the animation. And focal retinotomies can be done when there are star folds which are not possible to remove. Again, to do a retinotomy or retinectomy, we very often, earlier we were using the scissors. Today with the vitreous probes you could do it much comfortably. Especially when the retina is not elevated, you have to be careful that you don't damage the underlying choroid because it calls for bleeding. So ensure that that part of the retina is lifted before you cut the retina in these situations. Just to show the successes in this case of retinotomies, in one of the largest series in MOVE fields, it was shown that the primary success rate was only 51% with final total redetachment rate of 72% in those cases where extensive retinotomies were done. Retinotomies for access, as I said, mainly to access the subretinal fluids or bands, neovascular membranes. It's basically done depending on the size, the location, or the type of tissue that you need to remove from the subretinal space, the instruments that are available, and especially the dominant hand of the surgeon, so that you make the retinotomy in an area which is convenient for the surgeon to access that part of the subretinal space. The drainage retinotomy is most commonly done preferably in the superior nasal quadrant, where you could tamponade it easily. Especially you would do a posterior drainage retinotomy only in the cases of a pre-existing anteroretinal tear. In case of subretinal bands, you do remove those bands only if you are sure that this band is causing traction and keeping the retina from flattening. Otherwise, you don't need to remove all the subretinal bands. But if you have to remove them, you can make a small retinotomy and you could easily remove them through the retinotomies, as you can see in this video, where the subretinal band which is causing traction has to be relieved to flatten the retina. Because sometimes the retina would flatten under the PFCL, and then after some time when you do a fluid arc exchange, you realize that there is a small elevation because of this. So you ensure that all these bands are removed to flatten the retina. In case of subretinal hemorrhage, unclotted blood, the drainage is easier. You can use perfluorocarbon liquid to remove the blood anteriorly through a retinal break, or in clotted bed you may have problems. You would have to use the TPA in such cases. Subretinal foreign body, posteriorly located and specially mobile foreign bodies, foreign body in detached retina need this approach, wherein you would have to go in and do a posterior retinectomy or retinotomy and remove this the foreign body, and also you would have to do a laser photocoagulation surrounding this area in case this is a very large retinotomy that is made. Subretinal cysts, you don't see this more often. This is a case where the retina, you make a retinotomy closer. I had to use a forceps in this, but usually when you make a small retinotomy, the cyst tends to ooze out through that, just comes out through the small retinotomy, squeezes itself and comes out very easily. When you have a napkin ring membrane around the disc, very often you flatten the retina, but you see the edges of the disc alone is elevated. Obviously there is some membrane that's holding the retina from flattening. You need to go behind the retina, maybe do a almost 180-degree retinectomy to access the space to remove this membrane. Otherwise the retina is not going to flatten. So the intraoperative complications, you could have hemorrhage, retinal pigment epithelia, or choroidal damages, or subretinal migration of perfluorocarbon liquid could sometimes be a real headache in these cases. that Philip had clearly showed the retinal slippage, how it can happen in fluid-air exchange. In these situations, especially in giant retinal tears, a direct perfluorocarbon liquid or silicone oil exchange would help in such cases. In advanced PVR cases, anatomical success very often may not be possible in all cases, and the surgeon should definitely know when to stop or when to give up on these patients. Redetachments can happen due to various reasons, and it's been seen that in those cases of 360-degree retinotomies or retinectomies, the success rate is only around 50%. This is just a summary of the experiences that have been published, where you can see the success rate range around 70 or 80% in these patients. So in summary, the visual results are definitely guarded. It is very important when you take up such patients, you clearly explain the outcomes or the possible outcomes to the patient and their family, so that their expectations are not high. And the whole procedure depends on the surgeon's discretion on how you manage to remove the retina, that is retinotomies or retinectomies, and try to save as much retina as possible. Thank you.